All right, so now we're on to cyanotic defects with mixed blood flow. Mixed lesions are present in these different defects, and the degree of mixing and the amount of pulmonary blood flow will depend on the severity of the hypoxemia. One of the most common kinds is hypoplastic left heart, and that's the one we're going to discuss here in a few minutes. Okay. We have an inability of the blood to reach the body, so then these patients will have symptoms of low cardiac output. They may have diminished pulses, poor color, and poor capillary refill time. They're going to have decreased urine output. They're going to have signs of diminished blood supply to their GI tract, which means they could have necrotizing enterocolitis. Because the blood cannot move past the obstruction, it will then back up into the left atrium and then the lungs, which will then produce congestive heart failure with pulmonary edema. The extent of these obstructions determines the extent of the symptoms. Okay. The left ventricle should attempt to overcome the diminished blood flow produced by that obstruction with greater and greater pressure, and then that left ventricle becomes thicker and thicker and muscle bound, which means that that muscle will eventually wear out and weaken to the point of the left ventricle failing or poor cardiac output. Okay. However, you will see there's something slightly different with hypoplastic left heart syndrome that kind of changes this scenario a little bit. All right, so here, okay, so this is hypoplastic left heart syndrome. You will notice that the left ventricle is almost non-existent, and that right ventricle is super large, and it is having to maintain the circulatory system for the whole heart. You will notice there is at least one thing that is still visible on this diagram that baby had when it was in utero. Okay, we will learn more about why that is so significant. Here is a diagram of some of the first surgeries that you will see with hypoplastic left heart. There are 3 surgeries. We will be finding out about that soon. All right, so hypoplastic left heart syndrome. We have an underdevelopment of that left ventricle. Okay. Patients with this condition, the left side of the heart is unable to send enough blood to the body. As a result, that right side of the heart must maintain the circulation for both the lungs and the body. Okay. This extra workload will eventually cause that heart to fail because that right ventricle will continue to get bigger and bigger and bigger and muscle bound and eventually fail. These kids may have mild cyanosis and signs of congestive heart failure at birth. But the thing that is keeping them alive is that patent ductus arteriosus. Remember that ductus arteriosus closes within 10 hours to a few days after life. Once that ductus arteriosus closes, that child is going to have progressive deterioration. You're going to see that cyanosis get worse, the decrease in their cardiac output, and eventually cardiovascular collapse. This could end up taking days to months. Okay? So, what are we going to do for these kids? We are going to stabilize them with ventilation. So we're going to try to breathe for them. Okay? Then we're going to give them prostaglandin E's. Prostaglandins help keep that ductus arteriosus patent. So we want this child to continue to have a patent ductus arteriosus because that is going to help with the maintaining of the blood flow to the body. and the circulatory system. Okay? So, the only possibility of survival is that connection. Okay? So, we're going to give them prostaglandins to keep that ductus arteriosus open. All right. So, just to give you something to think about, this doesn't have anything to do with hypoplastic left heart, but something that I know will probably show up on boards for some of you. What do we do if we want to close that ductus arteriosus? It's patent. It doesn't close on its own. Well, we want to inhibit those prostaglandins. Okay, so prostaglandins keep the duct open. So we want to give this child something to inhibit the prostaglandins to close it, and that would be indomethacin. Okay. Indomethacin has its own requirements of things to needed. A separate IV. We have to watch urine output, things like that. Okay. So, if a child with hypoplastic left heart ends up getting indomethacin, it could be potentially fatal for this child because we're going to close that PDA before it needs to be done. Okay? So that's something to kind of think about there. All right. So, the only way this child is going to live is to get their first surgery. Okay, so they're going to get those prostaglandins to keep that ductus arteriosus patent until we can get them into surgery. Hopefully, we will get them into surgery within hours to the first few days of life. Okay, this first surgery is called the Norwood operation. Okay. This procedure consists of building a new aorta and putting in an artificial shunt. And this will help maintain that blood flow to the lungs. After the Norwood operation is done, these children will go home. They will need to take daily cardiac medications to help with their heart beating, their blood pressure, things like that. Okay? They are going to be followed very closely with a cardiologist. And then from there, they will determine when the second surgery will be done. Okay? These babies will still have a baseline of cyanosis all the time. So these parents won't be calling in and saying, my child's cyanosis, the thing's getting worse. We're not going to be able to tell. Okay? So we have to look at other symptoms. Okay? The second stage of surgery is called the Glenn-Shutt or the Hemi-Fontan procedure. Okay, this is done typically around 4 to 6 months of age. With this procedure, we are taking the superior vena cava and moving it around and connecting it to the lungs so that we can have that oxygenation going on. Okay, once again, this kid will still remain somewhat cyanotic as a baseline. This is a picture of second set of surgeries. Okay, just to kind of give you an idea of how that heart is changing shape. All right. The final stage of surgery is called the Fontan procedure. This is the remainder of those non-oxygenated veins or the inferior vena cava that gets reconnected. Okay, this now allows that right ventricle to serve as the only pumping chamber of the heart. Okay, this surgery is not done until that child is a toddler, 18 months to 3 years of age. After this surgery, this child is no longer going to have that baseline of cyanosis. Okay, after all these repairs, we will still monitor this child for dysrhythmias and to see how that ventricular function is going. These kids will be on cardiac meds. These kids will be followed closely by cardiologists for the rest of their life. Okay. If we do at least that first surgery, this child's prognosis of life goes from basically nothing to 75%. And then with each surgery, it gets better and better. Okay. Later in life, they will need more surgeries, especially if they develop arrhythmias or procedures start having complications. Many people have asked me, well, why don't we do a heart transplant on these kids? That's a great idea, but something to think about is an infant needs an infant heart. They can't get a heart from anybody because an infant heart's the only thing that's going to fit in that chest cavity. So there's very limited infant hearts. Okay. Also, we have those long-term things with heart transplants. You know, they're going to be on anti-rejection meds the rest of their life. They sometimes need multiple transplants. So some things to think about that way as well. These kids will sometimes get heart transplants. They do put them on lists, but we have to at least do parts of the surgeries before they can get a transplant. And we definitely have to do the first surgery because they're not going to get a heart that quick usually. So there is some chance that these kids will get heart transplants when they're young. They may not even consider the heart transplants for these kids until they're into adulthood. So let's do all the repairs, and if they continue to have complications, then at that point, we will go ahead and put them on the transplant list and get them a transplant if one becomes available. Here is what the heart looks like when it's fully repaired, that bottom picture. So you can kind of see how that right ventricle is maintaining all the circulatory system for the heart. I have taken care of a couple kids before surgery, before that first surgery, and then the PICU takes over. Then there's been a few times when I've been pulled down to general peds floors after they've been released from PICU after some of the surgeries as they're continuing to stabilize before they go home. The change I've seen in some of those babies after just 2 surgeries have been impressive. These babies that have these failure to thrive, tiny, hardly can eat, just huffing and puffing away, basically lifeless. Seeing them smiling, cooing, putting on weight and having little fat rolls, eating bottles, laughing if they're old enough to start laughing, reaching milestones is so impressive. So just kind of thinking that we're putting these kids through a lot of things, but once they have these surgeries, you start seeing these major changes in their system and their livelihood. So it's kind of neat to see these things. What's our role when we're dealing with congenital heart disease is managing up, making sure that parents are understanding what's going on, getting the medications, monitoring the cardiac and respiratory status, prenatal care education to the family to prevent future pregnancies with kids with heart diseases. But also, as that child gets older, when they have some of these chronic heart issues, they actually are recommended to not get pregnant because of the demand that pregnancy puts on their system, and it could actually make them worse. Making sure that child is comfortable as we're doing all these different lab tests and procedures as well. All right, I think that's it for all of our cardiac stuff. If you have any questions, let me know.